I'd like to invite Dr. Manoj, the Senior Consultant in Retina Chaitanya Hospital, to give his talk about an approach to retinal venous occlusions.
Thank you. Thank you, Dr. Uni. I'll be talking to you on an algorithm-based approach to retinal vein occlusion. Now, we all know that it's an important disease too, along with diabetic retinopathy. It's a common retinal vascular pathology, and because of its implications, some of these cases, if left untreated, can lead to permanent visual loss or blindness. And more importantly, there is a strong systemic association with this disease. There's a higher incidence of cardiovascular events, including stroke, that is associated. So my algorithm is this: like whenever we see a patient retinal vein occlusion, first we would like to see if the patient. Typically, the vein occlusion is a disease of the older age group. And when you see a young patient, then these patients can be considered a distinct clinical entity because they have more favorable prognosis, the complications are less, and sometimes they have a self-resolving course. And we need to understand that nearly 1/4 of these eyes have an inflammatory basis. And the phenotype in these situations is usually a central retinal vein occlusion than a branch retinal vein occlusion. So, and then we would like to see if the occlusion is basically unilateral or bilateral. Predominantly, retinal venous occlusions are unilateral diseases, but when you see it bilateral at presentation, then this is seen in 4 to 7% of cases, and it means that you require some additional testing because the etiologies may be slightly different. You're looking at hypercoagulable states, hematological malignancies, or even inflammatory diseases. So these have to be considered. So even in unilateral cases, one needs to first rule out if there is an inflammatory, sign that is associated. Look for inflammatory signs. Like for example, if you have a BRVO and if it does not respect the typical AV crossing change, then you're thinking of an inflammatory, vein occlusion. But we know the commonest cause is thrombotic, and where we would like to classify vein occlusions into central retinal vein occlusion and the branch retinal vein occlusion. HCRVO, hemicentral retinal vein occlusion, is considered part of CRVO because they share the same pathogenesis and in terms of prognosis and treatment. And they're overall they're classified into non-ischemic and ischemic. And we also know how to differentiate them. Ischemic CRVOs typically have RAPD. If you take an FA in these patients, they have extensive CNP areas, and even on the ERG, there is a reduced B wave amplitude. All this can help us to differentiate between an ischemic and a non-ischemic CRVO. BRVOs, on the other hand, we would like to see if the BRVO suggests a macular BRVO, whether it's a major sectoral branch vein occlusion, or is it a hemispheric vein occlusion, where one half of the retina, which is supplied by an abnormal vein, the AV crossing change is affected, and therefore now you have a picture which looks like hemi-CRVO. So this needs to be differentiated because the prognosis is slightly different between these two entities. So, and we also know that if you perform an FA and then if the CNP areas are more than 5 disc areas, you would like to call it an ischemic BRVO. So investigations, in a typical case, these are the common investigations that you would do. But when you have patients under 50 years, or when you have a bilateral presentation, then you need to look for antiphospholipid antibodies, antithrombin 3 levels, activated protein C resistance, factor 12, and even look at some inflammatory markers, treponemal, non-treponemal tests, and even quantiferon gold. So in terms of prognosis, the first thing that I would look at is the baseline visual acuity, because we know from the CRVO study and from the BRVO study that baseline visual acuity is very important. If you have a good visual acuity at baseline, then these patients tend to do well with or without treatment. With poor visual acuities at baseline, like worse than 660, these patients, in spite of good treatment, they would still, many of them may end up with poor visual outcomes. Now, this is the same thing with BRV also. Most of the studies have shown that the final visual acuity is strongly dependent on the initial visual acuity. The next thing we would look at is we would normally perform an OCT in these patients to look for macular edema. Subtle macular edemas may be missed, so therefore it's important to perform an OCT in all these patients. And we look at the CFT. The CFT is again the next important prognostic marker. When the baseline CFT is higher, then then it is a poor prognostic marker. It is a predictive factor for final visual acuity after anti-VEGF therapy. Like there are studies which have shown that if the CFT is more than 500 microns, so now these patients may tend to do better with steroids than anti-VEGF agents. And we also look at other biomarkers. We look at the presence of intraretinal fluid, the subretinal fluid, hyperreflective foci, and other OCT biomarkers. SMT is generally considered a good biomarker, and people believe that no, it may respond better to steroids as against intraretinal fluid. Intraretinal fluid, especially in the ganglion cell layer, is believed to be very detrimental and causes very poor visual outcomes. We also look at these biomarkers where the disorganization of the inner layers, called the drill, or even the disorganization of the outer layers, which is now called as a drawl, where there is an ellipsoid zone loss. So these are bad prognostic markers. It means that there is it is a strong association with macular ischemia and poor outcomes with whatever treatment that you give. Also, you look at the red arrow shows the prominent middle layer membrane, and the yellow arrow shows the PAM-like lesions, middle layer maculopathies. So these are lesions which tell you that that the severity of ischemia is more, or there is an arteriolar component to that, and the prognosis again poor in these patients. Like this patient that we saw here, this patient had macular edema with macular ischemia, and in spite of anti-VEGF therapy, this patient is not doing well. And then we realized that there is a small dilated arteriole sitting there, which is like more than 200 microns. So this is a retinal capillary macroaneurysm. So this has been reported in both diabetic macular edema as well as in vein occlusion. These patients are resistant to anti-VEGF therapy. So doing a laser to this lesion and with the orthodex, you see a good anatomical response in this patient. We also have understood that ultra-wide field imaging is very useful in these patients because there is a lot more ischemia that we pick up on these imaging system. There is an ischemic index, which if it is between 35 to 45%, it's strongly suggestive of ischemic vein occlusion and poor prognosis. And these large CNP areas are associated with recalcitrant macular edema and higher anti-VEGF burden. And now with the advent of OCTA, this is the intralight system that we use now, which gives us wide-angled OCT images, like 29 into 24 images. You can pick up all the perfusion gaps, you can pick up these abnormal vessels, and you can also this is a patient where you see a lot of collaterals that you see in the sectoral region of the branch vein occlusion. And identifying collaterals is important because now OCTA-based studies have shown that collaterals are picked up much earlier, not at the 3 to 6 months of the disease. It's seen in almost 82% of cases, even at baseline. And if you have a collateral, it's a good prognostic sign. Earlier the collateral develops, there's a chance that your macular edema is going to get better, and the resolution and the final visual acuities are going to be better. Also now with the Octa, we can now look at the deep capillary plexus as against the superficial capillary plexus. Being a venous disorder, you would see more changes in the deep capillary plexus. And there are a lot of poor prognostic markers that have been described. The ratio between the deep and the superficial plexus. And all these variables have shown us that if there is a deep capillary plexus which is severely involved, then these patients have a poor visual outcome. They have persistent macular edemas, and there is an increased anti-VEGF burden. Like in this patient here, this patient was treated and had a good anatomical response. But if you look at the superficial capillary plexus that is shown there, it looks nearly normal with the collateral, but the visual acuity is poor. But if you look at the deep capillary plexus, you can see there is an enlarged FAZ. And it is this deep capillary plexus ischemia, selective ischemia, that could explain the visual loss in these patients. We know that anti-VEGF therapy is a mainstay of treatment in these patients, and we have understood from the trials that you need to be intensive in the first 6 months of therapy to attain meaningful vision gains. So we also now understand how to define a poor responder. A 3-month guide is a good one. Like if you have at 3 months you do an OCT assessment, if there's a good response, good complete resolution of fluid, it's a good responder. But if you have less than 10% of decrease, then it is a poor responder. And if you have around 10% or more, then it is a partial responder. So now this difference can be made out at 3 months, and you could use this as a guide to continue with your therapy. Also, there are guides which biomarker indicators which tell us that some of these may respond better to steroids, like presence of a thicker CFT at baseline, or like presence of hyperreflective foci or persistent subretinal fluid. All these are prognostic markers which tell us that steroids may be better than anti-VEGF. So that they will tell you when to switch to steroids. So this is my algorithm. In a non-ischemic CRVO, when you have macular edema, we start off with anti-VEGF and look at the 3 months trend. If it is a good responder, continue, and it's a good prognosis. But if it is an inadequate response, you look at the OCT biomarkers at that point of time, look at poor prognostic markers, and you could persist for another 3 months because the trial says you could that some people may respond a little later. And at 6 months, if you don't, you need to switch. Or you could even switch at 3 months to a different agent. And I think the time's up. Sorry, I'll just take 2 minutes. So in an ischemic CRVO, obviously you would also add laser photocoagulation along with this. And the protocol essentially, the OCT guidelines are essentially the same. Look at the good responders and the inadequate responders and go ahead. And BRVO also, so there's not major difference in treating macular edema between the two entities. Looking at OCT guides, you can decide whether or not you need to switch or continue with the anti-VEGF therapy, but you need to monitor for macular edema, macular ischemia, which are poor prognostic factors, and also treat whenever there is a new vascularization or its complications. So this is my final take on unfavorable outcomes. You need to pause at 3 months and 6 months and reinvestigate. Look for unfavorable outcomes on the OCT, look at ultra-wide field imaging or OCT clues, and then reinvestigate systemically at that point. Look at other comorbidities, and then have a low threshold for modifying the protocol or agent or adopting other treatments. And targeted PRP, though not proven to be consistent, I feel, it may not be detrimental in these patients and should be adopted. Thank you.